Welcome to the lecture entitled Principles of Gross Anatomy. My name is Carlos Andres Suarez-Quian. I am the creator and narrator of this lecture. Before I begin, I want to dispel the notion that gross anatomy is one of those courses that is impossible to master, that the language is just too obscure to learn. I want you to grasp the concept that anatomy is truly the science of the obvious. The reason that you might think otherwise is that the Greeks and Romans labeled everything before us, and their vernacular was retained because early anatomists knew this language. Think for a moment of what you would call those appendages that extend from your shoulders. We call them arms. Romans also wanted to use an everyday term for these appendages, so they called them brachia, the plural of brachium, a term that has evolved from ancient Greek, brachium. So you see, anatomy is truly learning the mundane, albeit in Greek and or Latin, languages that we simply do not use anymore. Bear with me, anatomy is not really the bear of struggling to learn medicine. In this slide, I list the objectives of this lecture. First, I will define what is meant by gross anatomy. I will then describe the material we will cover in the greater course. I will describe the anatomical position essential to understand relationships between different structures of the body. Finally, I will describe how to use anatomical terminology to describe body planes, regions, directions, and movements. The term anatomy originates from the ancient Greek term temnion, which translates into cutting open. Indeed, in the past, an anatomist would not be dissecting, but rather anatomizing a cadaver. Anatomizing was the term used for dissection until approximately the 20th century. Anatomy represents the study of the internal and external structures of the body and the physical relationships between parts. Knowing anatomical information provides the clues about probable functions, and physiological mechanisms can be explained only in terms of the underlying anatomy. What this means is that all specific functions are performed by specific structures. Indeed, this helps explain why the study of medicine and disease should be straightforward. If you know the structure, you should be able to figure out its function. Hence, pathology is simply the what happens to the structure when something goes amiss. Unfortunately, as you will see shortly, by stating that anatomy incorporates the structure of things, even at the molecular level, there are untold numbers of diseases that we simply do not know their mechanisms that elicits the pathology. The language of anatomy, as in all forms of communications, is vital. It is a foundation by which we let others know what we are thinking. Let me show you this brief clip to affirm this point.
Hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
At this point, let me clarify what we plan to do with all this language you will learn in gross anatomy. First, it is not just memorizing facts. Yes, you do have to learn the names of structures that use Latin and Greek in their base, But if you just memorize terms, as people used to do with a telephone book, you will not know your anatomy. An understanding of anatomy requires an understanding of the context in which the terminology can be remembered. Let's look at the three main branches of the aorta to understand this concept. Here, we see a dissected heart with the aorta still attached and labeled. Note the three large arteries arising from the aorta: the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. Clearly, you must ask yourself, why would anyone use such complicated language to label these vessels? Is it not much more straightforward to assign numbers? The short answer is no. Given the thousands of such vessels in our bodies, pretty soon you would be memorizing thousands of numbers that would have little meaning and easily forgotten. Instead, we use anatomical vernacular that has intrinsic meaning to label structures. Again, we use the known language to describe the obvious. First, note that we applied the term left to a couple of the vessels. This clearly implies that if there's a left side, there must be a right side. And indeed, the body is divided into the right and left sides by the sagittal plane. Why do we label these vessels arteries? Because arteries carry blood away from the heart. They are under much greater pressure than veins, and the walls of arteries are much thicker to withstand this pressure. All these facts have implications for arterial physiology and pathology, but first we have to describe the anatomy of the structure before we can understand its function. Moving to the term brachiocephalic, and what you call an artery that carries blood to the arm and to the head. In Latin, brachium means arm and cephalat means head. Again, think of the obvious. The left common carotid eventually divides into two major arteries, the external and internal carotids. Hence, when they're joined together, coming off the aorta, we say they're common. As to why they were called carotids, karos means deep sleep in Greek, and back when these arteries were first described, blood was envisioned to be one of the four humors that carried magical powers. Blood still does carry this magical power. It is called oxygen, among many nutrients and hormones. Finally, we get to the subclavian. This one's obvious. The subclavian artery carries blood to the upper limb by first going just under the clavicle. Clearly, we use anatomy in a straightforward way to label structures based on their location and function. As alluded to in the introduction, the study of anatomy is the study of all structure. However, we're limiting our study to gross anatomy. What is this limitation? If you focus on the image for a second, you will see that we can see structures with different tools, including the transmission electron microscope, the scanning electron microscope, and the light microscope. However, if we do not need a microscope to see a structure, then that is the realm of gross anatomy. With an unaided eye, we can likely see a human egg and larger structures. Anything that can be seen with the naked eye is the subject for gross anatomy. To clarify then, the purpose of gross anatomy is to introduce you to medical terminology. For the most part, anatomical structure will be presented at the gross level in a clinical context. Dissection of human cadaveric material will not be part of this course, but there will be an opportunity to visit the laboratory and see prosected cadavers. And finally, every so often, we will touch on conventional and modern imaging techniques such as X-rays, CT, and MRI. And to be clear, the anatomical vernacular that we'll use here is a language that was internationally agreed upon nomenclature with Latin and Greek roots forming its basis. This agreed upon language is the nomina anatomica. A meeting was held in the late 19th century to try and make sense of the 50,000 terms for various body parts that were in use, including eponyms at the time. Work began in 1887. It was approved in 1895 in Basel, Switzerland at the 9th Congress of Anatomy Gesellschaft. Work continues to this day. The British National Association reduced anatomical terms from 50,000 down to 5,528. However, the French anatomists prefer to continue with their own traditions, and today their books are much denser than anything in English. The next question to tackle is, how will the gross anatomy be presented? Given that the ultimate goal of learning anatomy is to understand function, some anatomists took it upon themselves to present gross anatomy in terms of physiological systems, of which there are 11. The famous British anatomy textbook, Gray, uses such an approach. Many schools, principally here in the US, however, use a different approach. Instead, we teach gross anatomy using a regional approach, and there are 7 distinct regions in the body. These include the head and neck, the upper limb, the thorax, the back, the abdomen, the pelvis and perineum, and the lower limb. We will use this regional approach to teach gross anatomy. Before starting the description of structures we will observe in the different regions, we need to present the anatomical position. This is the standard reference position for which all other structures will relate. In this position, the patient, even if lying down, is envisioned to be standing upright with the feet together and the hands and feet pointing outwards. The fingers are together. In the male, the penis is considered being erect in the anatomical position. Further, in the anatomical position, the body can be imaginarily sliced into planes. Anatomists have used these slices or planes to present the gross anatomy in terms of relationships of the structures. These planes include the following. First, we have the horizontal plane, so called because the horizon slices the field of view into earth and sky. It is also termed the transverse or the axial planes. Indeed, CT imaging is usually presented as axial images of the body. The horizontal plane divides the body into a superior and inferior relationship of the structures. However, do not think that the plane is static. It is not. Depending on where you image the plane, a particular structure can be said to be superior or inferior to another. Next, we have the coronal plane. The term derives from slicing a crown that sits on top of the head in an anterior to posterior direction. The last plane is the median sagittal plane. The term comes down from Sagittarius, the mythical creature that was half horse, half man, and would shoot arrows. Given that the chest is the widest point in the anatomical position, a bowman aims for the chest. This plane separates the body into right and left. The median sagittal plane is the precise midline of the body. If the plane is deviated to either side of the precise midline, then the plane is simply known as a sagittal plane. Additional terminology exists to describe how the planes separate the body in the anatomical position. This terminology is based on the evolutionary principle that we started off on all four legs, not two. For example, the coronal plane, in which we stated that it separates the body into an anterior and posterior division, can also be said to separate the body into ventral and a dorsal division. Think of being on four legs as to why this makes perfect sense. The transverse plane can also be said to separate the body into cranial, towards the head, and caudal, towards the tail. The median sagittal plane, however, only separates the body into a right and a left side. By this point, you might be thinking that this terminology is a bit much. Why must someone be so precise in its use? Let me give you some examples where not knowing this terminology accurately is a life or death mistake. On the left panel, we show a dissection of the neck in the coronal plane. On the right side, we show the dissection of the neck in the sagittal plane. Let's label the trachea in both and the esophagus in both. Note that the trachea is anterior to the esophagus. Why am I not knowing this fact be your life or death mistake? Think of an anesthesiologist who must intubate the trachea for the patient to live. If they intubate the esophagus, no amount of air will resuscitate the patient. Let's look at another example where knowing your anatomy allows you to make a diagnosis. Here we see a chest dissection. The heart is in its casing, the pericardium. The ascending aorta is now labeled. The left vagus nerve is labeled. Note, this is the left side of the body. The right vagus is now labeled. The left recurrent laryngeal nerve, a branch of the left vagus, is now labeled. Finally, the right recurrent laryngeal nerve, a branch of the right vagus, is labeled. As you will learn when we study the chest, the left recurrent laryngeal nerve originates in the chest, whereas the right recurrent laryngeal nerve never makes it into the chest. Why is this important? Because a tumor growing in the chest may manifest with impacting the left recurrent laryngeal nerve and will lead to voice hoarseness. Think of a smoker who may have an undiagnosed tumor in his or her chest. If the left recurrent laryngeal nerve is impacted by the tumor, then this could lead to a physician to look for a tumor in this area. Anatomical knowledge often allows one to make a diagnosis. The last example of how terminology is vital to understanding anatomy and pathology is shown here. Superior versus inferior. I'm showing you a dissection of the thorax and the abdomen. As you proceed with learning your gross anatomy, images such as these will become easily identifiable. The liver and the stomach are now labeled, and note how these two are way below the heart. A diaphragm clearly separates the two compartments. Indeed, this is what one would expect to see when you open a cadaver or in a patient who has normal anatomical distribution of the thoracic and abdominal organs. However, what can go amiss? Here, I show a different dissection of the thorax, but to the trained eye, one can immediately observe that something is amiss. Yes, the heart is in a similar location. The diaphragm is below the heart. But now there is something in the thorax that does not belong there: abdominal viscera. In this individual, the stomach punched through the diaphragm and part of it is now in the chest. This is called a hiatal hernia and leads to the painful condition known as esophageal reflux. In certain cases, the condition can result in esophageal cancer. The hiatal hernia is not clearly demonstrated in this cartoon from Adam. The presence of the hernia above the diaphragm would have been initially reported as an abnormal mass superior to the diaphragm. The actual way this was likely diagnosed years earlier was with the use of imaging. Using conventional X-ray technology, the panel on the left shows a lighter shadow at the arrow. This shadow is highly indicative that the stomach punched through the diaphragm and relocated superiorly to its normal location. No light shadow should be present at this level of the thorax. On the right panel, I show a diagnostic test, an upper GI series, where an electron-dense material was infused into the stomach through a nasogastric tube. The electron-dense material is now filling the stomach. But note that all of the stomach is no longer exclusively located in the abdomen where it belongs. It projects into the thoracic cavity as a hiatal hernia. Clearly, this is not the esophagus, but the stomach was repositioned itself after punching through the diaphragm. In the description of this patient, it would be noted that the stomach is much superior to its normal location. Continuing with essential terms of anatomy, let's mention medial versus lateral. Recall that the median sagittal plane divides the body into right and left, but now we're going to use the sagittal plane to relate structures to the median sagittal plane and use terms such as medial and lateral. We define structures relative to the median sagittal plane which remains fixed as a standard. For example, the clavicle is medial to the shoulder, which is lateral to the clavicle. The sternum, however, will be medial to the clavicle. In brief, the position of all structures will be relative to one another, keeping the median sagittal plane fixed. We can also discuss the relative position of structures with respect to the coronal plane. If we start at the skin and proceed dissecting into the cadaver, it is said we're going superficial to deep. In contrast, if we are describing structures of the abdomen located closer to the back, relative to structures closer to the abdominal skin, we would say these structures are deep relative to superficial structures. Going back to the median sagittal plane, we can also use the terms superficial to deep with respect to the positions of structures as we explore the cadaver in a lateral to medial direction. Superficial to deep are synonymous terms with lateral to medial in this plane. In turn, we can also describe deep to superficial related structures instead of medial to lateral placed structures, but the meaning is the same. Again, let's give clinical meaning to the terms of superficial to deep. I'm showing you the medial aspect of a dissected lung. The vessels and bronchus enter the lungs at its root. Anterior to the root of the lung is a major nerve, the phrenic nerve. Posterior to the root of the lung is the location of the vagus nerve. As you can imagine, both these nerves are located rather deep in the body. However, if you approach the chest from the front, the phrenic will be described as being located anterior to the root of the lung, whereas if you approach the body from the back, the vagus will be the one that earns the moniker anterior to the root of the lung. This might seem trivial to you now, but to a surgeon performing laparoscopic surgery to remove a tumor at the root of the lung, these terms are vital to keep in mind depending on the approach. Of course, the most superficial of all structures is the skin. In gross anatomy, we really do not focus much on the skin because we do not see many of its vital layers that provide it function. For example, what we call skin is really made up of the epidermis and dermis, but with our naked eye, it appears as a single layer. Deep to the skin, we will encounter the superficial fascia, what appears to be to the naked eye as a fatty layer. It is also rich in nerves and small vessels. Deep to this layer is the deep fascia, and of course, you must have realized this was coming because I previously mentioned superficial fascia. If we only have one type of fascia, we would simply call it fascia. However, we have two, the superficial and deep. The deep resembles a clear membrane that envelops the muscle. Skin is not simply a wrap of the body, as you'll cover much of its function in another course. In general, the functions of the skin include protection, containment, heat regulation, sensation, and synthesis and storage of vitamin D. Here, I show you two distinct dissections. Note the skin, which has been peeled or reflected from the cadavers. The fatty, superficial fascia is clearly visible. And note the differences between the amount of superficial fascia that can be present in diverse cadavers. Also, in some cadavers, superficial fascia can be almost missing due to prolonged illness prior to death. To see the deep fascia, I made a horizontal section through a cadaver that is now shown. Again, I can point out the skin, the superficial fascia, and now the muscles. Those thin, whitish lines that encase the muscles are the layers of deep fascia. Now, let's talk briefly about Langer lines. Even though this is really the area of microanatomy, you should be aware of them and the importance they play in surgical approaches, the realm of gross anatomy. These lines were first discovered by the Austrian anatomist Karl Langer, and these are microscopic tension lines that follow the collagen fibers in the dermis and are generally oriented perpendicular to the underlying muscle fibers. Surgical incisions are made parallel to these tension lines because they allow for distension of skin, the incision will heal better, leaving little scarring. In contrast, incisions perpendicular to these lines are more likely to produce keloids. Ice picks produce slit-like wounds rather than rounded cuts. Indeed, it was the use of a tool similar to ice picks that led Langer to propose the existence of these lines. You may actually know of these Langer lines already, but call them something else. The stretch marks associated with late pregnancy are because the Langer lines are being distended. Technically, stretch marks are known as stria gravidarum, when they are in pregnant women. The lines may appear on the abdomen, as shown here, but also the buttocks, thighs, and breasts. In obese people, lines will appear also and are called stria distensae. They're caused by the rapid increase in size that damages the collagen fibers of the dermis. Back to terms of orientation. Previously, we discussed that the median sagittal plane separates the body into right and left. Also, however, we use the terms proximal or distal, near versus far, to relate the position of a structure relative to the median sagittal plane. For example, the wrist is distal to the elbow, and the elbow is distal to the shoulder. In turn, the shoulder is proximal to the elbow, and the elbow is proximal to the wrist. In these reference relationships, distance, whether something is medial or lateral to another structure, is measured in a contiguous fashion, beginning at the median sagittal plane. Distance is precisely not how the crow would fly from the median sagittal plane. Hence, you cannot place your hand on your belly and claim that it is now proximal to the elbow. The wrist will always be distal to the elbow. Having spent all this time speaking language vernacular, it would be somewhat boring if this language did not also have action terms, and fortunately it does. Let's discuss them now. First, we say that a structure can adduct or abduct if it moves towards the midline, or abducts if it moves away from the median sagittal plane. The classic example of demonstrating the action of abduction is to demonstrate the upper limb moving away from the midline, as is now being demonstrated in the figure. If we now move towards the midline, we are adducting the upper limb. In this example, we use the midline as the reference point. In reality, adduction and abduction refer to movements to and away from any part as long as we define a central location. The fingers, for example, abduct away from the middle finger and adduct to the middle finger. Let's look now at the terms of flexion and extension. These terms refer to closing a joint. For example, decreasing the angle of a specific joint is to flex that joint, whereas opening the angle is to extend the joint. Here we see the elbow joint undergoing flexion and then extending again. Extension, however, does not necessarily only occur at the elbow joint. We can also extend our shoulder joint and as well flex our shoulder joint. Indeed, if you think about it, you can both extend your shoulder joint and flex your elbow at the same time. The next terms to define are pronation and supination. These terms refer to the internal and external rotations of the forearm. In the anatomical position, the palm of the hand faces forward and is said to be in the supine position. When we rotate the palm to face backwards, the palm becomes pronated. A common mnemonic to remember these terms is to think of what you would do if you had to drink soup without a spoon. You would need to cup your hand and get the soup with a supinated palm. And here's the example in images. The hand in the anatomical position, supine, is being moved into the prone position and then back again into the supine position. The last action term to mention is circumduction. Circumduction refers to the circular, or more precisely conical, movement of a body part, such as a ball and socket joint or the eye. It consists of a combination of flexion, extension, adduction, and abduction movements in sequence. Windmilling the arms and rotating the hand from the wrist are examples of circumduction. You do circumduction when you throw a baseball. This now concludes the lecture on the principles of anatomy.